Okay, thank you. Right, I'd like to welcome you all to the West Suffolk CCG September board meeting, which is also the annual general meeting for this year. Ed, would you like to introduce the concept of what's probably our final annual general meeting as a CCG?
Yeah, thank you, Christopher. So I'm very happy to introduce the annual report and accounts as part of the AGM, and I think it's as you say, given it's our final meeting, it's a good time to look back on the last decade, which has flown by in so many ways. But the CCG was born into a kind of an era of competition. That was the predominant culture at that time, and we saw very competitive relationships between NHS providers and between NHS Commissioner as the new CCG and the provider. That was the culture at the time. But what we wanted to do from the outset was create what we described back in 2012 as integrated working, and we've been true to that all the way through. And I think we've been very much ahead of many areas of the country in doing so. By 2014-15, we launched with Suffolk County Council a health and care review, which was around exploring the concept largely of developing integrated health and social care teams in localities. And during that time, I brought a paper to this board around the idea of creating an alliance for West Suffolk, which was supported and was replicated very quickly in Ipswich and East Suffolk. And I think all of that investment of time and relationships and collaboration couldn't have been more important with hindsight going into the pandemic that we've had in the last 2 years now. We've been able to keep resilient and innovate and to reform as a result of all of that time we put in as an alliance and as a really a group that's focused on our communities and integrating services in our communities. And we've seen such strength in those communities, haven't we, of how they've supported their families and their neighbours and their townspeople. It's been absolutely incredible. We've seen integrated neighbourhood teams mature so quickly, and primary care networks really come to the fore. We've seen social prescribing, and the annual report described in the introduction the LifeLink work we've done collaboratively with West Suffolk Council and the impact of that. And we've seen a number of integrated models. The end of life work comes to mind, but we've seen a huge change in the way we work with care homes as another example. And we've seen strong developments around mental health transformation that's kept momentum. And I think possibly most importantly, we've done an absolutely fantastic job on the biggest public health prevention programme that I think we've ever seen in terms of COVID vaccination. And there's no doubt that we've saved many lives and protected many people as a result of that programme. And I thank everyone in a heartfelt way for everyone's contribution to that. It's worth reminding ourselves that we have lost colleagues in Suffolk as a result of COVID, and many people have been very unwell too. So that would be my kind of précis, Christopher. I just wanted to thank everyone on the board for their leadership during the past year, and everyone in the West Suffolk Alliance too. I think it's been magnificent, and I'm very proud to be part of it. So thank you.
Thank you very much, Ed, and I would like to echo my thanks to everybody involved, past and present. The CCG journey began for me in about 2009 when I was catapulted to be chair of the then practice-based commissioning group for the west of Suffolk, because Godfrey was going to be chair of the LMC, and life plays funny things, doesn't it? I think we also owe you a personal debt of gratitude, Ed, for having been with us in the West throughout the journey, from inception, when we were authorised. An awful lot of work you did then, you continue to do so ever since. And we all, I'm sure, wish you well in the appointment process for the lead of the new ICS, which is currently ongoing. Thank you. Before we do the accounts, Jane, can I just say that I forgot to do apologies. So could you formally record the apologies, please, Jo?
Yeah. I've had apologies from Jeff Dobson, Godfrey Reynolds, Barham, and Andrew Yeager.
Thank you very much. Right. Thank you. On to you then, Jane.
Yes, thank you, Chair. So, so it's my job to give you a brief summary of the accounts, but before I do so, just to commend to you to have a look at the annual report that is included in the pack. Whilst we have produced this annual report under the COVID regulations around annual reports, so it is slightly shorter than we would have historically provided. I think it does provide still a really good summary of the activities underway in there. There's a whole section on the response to the COVID vaccination programme. It provides a real summary of what's going on within the Alliance, and would really commend particularly the opening section. The closing section is all important, all the statutory information about our workforce, our accounts, etc. But in terms of just getting a feel for the work that we've done within the CCG, I'd really commend reading the annual report itself. But moving on to the accounts, so within the pack of papers, I have included a couple of slides about the accounts. So I'll talk through those first, and then I'll move on to the second item, which is the audit report. In terms of the accounts themselves, the overall key messages for the accounts is that as a CCG, we achieved all the financial targets set for us for the year. So the main one of those is to live within the resources that we were given. So overall, we had income of just shy of 400 million for the year, and we spent 395 million of that, giving us a small surplus of 2 million, which is in line with the previous year. I think it's fair to say at this point it was a very unusual financial year for the NHS. We were working under emergency financial arrangements set out by the central NHS to try to help do a number of things. Firstly, to make sure that there was enough cash in the system to deal with the COVID response. So in our role as CCGs, we act as a system banker, and we pass through cash to our provider organisations, as well as to those areas that we buy services from. So rather than our normal arrangements where we would agree contracts with our main providers, and we'd spend a lot of time negotiating those and looking at the various bits and pieces that go into those plans and contracts, those were centrally prescribed and calculated for us by the central NHS team, and we acted as a pass-through arrangement for those monies in the West Suffolk CCG. That's particularly for West Suffolk Foundation Trust and for mental health services provided by Norfolk and Suffolk Foundation Trust. And what you'll see if you look closely at the amount of money that we spent as a CCG for the year, that was a significant increase from the previous year, and that's partly about those extra COVID resources passing through the CCG and passing on in some cases to our local providers. I mentioned our role in making sure that cash gets into the system, and it's really pleasing to report that we were a good payer as a CCG, and we paid over 96% of our invoices within 30 days, thus ensuring that cash was flowing around, and not only our NHS partners but also local businesses were paid quickly, and hopefully that we acted as a good corporate citizen in terms of our role there. I'm going to talk more at the end about the audit report, but one of the reasons why we're having our AGM later this year than normal is that the audit requirements changed for 2021 across the public sector to include a narrative report on the use of resources and value for money, which, as I say, I'll talk about a little bit more later. But moving on to the next slide, which is a sort of a pie chart with a hole in it. I think I described it yesterday as a bit of a pie crust graph, which shows the expenditure for the CCG over the financial year. And unsurprisingly, the vast majority of what we receive as a CCG flows through ourselves and passes on to buy services for our local population. And you'll see from that that the vast majority of that goes through to services that we buy from local NHS trusts and foundation trusts, but also a range of other CCGs and NHS England and other providers, including primary care. One of the larger areas within the chart being this expenditure that we make on prescribing and primary care within those. And looking at those specifically, our expenditure on prescribing increased by 8% on the previous year, although a large element of that being due to the COVID impact. And overall, our expenditure on primary care, including GP contracts, increased by 6.5% year on year. Moving on, if you're old like me, you call it the balance sheet, but more recently we now call this the statement of financial position. CCGs are unusual organisations in that we don't hold a lot of physical assets. It's not like a hospital where we would have set building and machinery. So in terms of our fixed assets, that's very low. We also don't hold large cash balances in our bank accounts, so we're given a cash allowance to make payments, but we draw down cash as it's needed from central sources. So you won't see large elements of cash on our balance sheet. Hopefully we just have small balances as we work through what we need to pay. So no major changes in our balance sheet from one year to the next. We have had a decrease in provisions, which has been around provisions that we had in place for potential costs around premises. But other than that, no particular changes from one year to the next. So moving on, we're obviously now well into our next financial year, which is 21-22, and as I've reported to the governing body previously, normal financial arrangements for the NHS have not yet come fully back into place. We are still working under emergency financial arrangements, and across the NHS we are awaiting announcements about the amount of funding that we will receive for the second half of the year, which is now getting perilously close given we're on the 29th of September. We do know the shape of that, but obviously we're waiting the detail of that to come through so we can see exactly how our plans, both for ourselves and for our provider organisations, will play out. The uplifts that we received in the first half of the year for services that we commissioned directly as a CCG, so prescribing, our continuing healthcare and primary care being the main ones of those, they have been at quite low levels. So we await the second half of the year allocations with a lot of anticipation to see how they will play through, but they are leading to cost pressures in the CCG that we are needing to deal with, and I'll talk more about that when we come to the finance report. We're hopeful that the 1st of April will see a return to a more normal allocation process whereby the CCG receives its share of the national pot on behalf of its population and is able to make decisions around that and plan for services in a more normal way. But as Ed and Christopher have said, we know that the CCG won't exist in its current format from the 31st of March. So what we will be doing is seeing the allocation across the wider integrated care system for Suffolk and North East Essex, which we expect to be a sum of the CCG's existing parts that move into that new organisation. However, we are keen that not only will that sort of larger counting block, that is the ICS, ICB, exist, we also are working hard to try and ensure that we're still able to report finances and allocations, both at the place level, so at this alliance that is West Suffolk, particularly for this meeting, but also more importantly down at locality levels so that we can support the primary care networks and integrated care teams to look at what they are spending, particularly in those areas where they can make a real difference. So we're working on how that will work as we move forward. So that's all I wanted to say on the accounts. Just moving on, if I may, Chair, onto the audit report that's included in the pack. This is a joint audit report which covers the 3 CCGs that make up Suffolk and North East Essex, which hopefully will help us to flow more smoothly into the new organisation as we move forward. It's a longer report than normal. As I say, it's delayed because of the new requirements around value for money. And you'll see in the report there's quite a long and detailed narrative about a number of areas that have been assessed for the CCG around our governance and our use of resources. And there's some, I think it's, well, it's overall, it's a very positive report, and it does highlight some areas of good practice within the 3 CCGs, which I think we should be proud of. As with all audit reports, you don't really get positive messages on those. What the positive message on use of resources is that we have no significant weaknesses being identified. So that's as positive as we can get. In terms of the overall accounts, the auditors commented on that earlier in the year and have included it in this report. And overall, it is an unqualified opinion on the accounts. So they present a true and fair view with no material issues in them. So that's all I wanted to say, Chair, and but obviously happy to take any questions.
We should thank you and your team very much for all the work that's gone in behind what is an excellent report, both in terms of accounts and in terms of a full box of green ticks from the auditors. Many thanks. Any questions? No? Okay. Oh, Ed.
It's just I'm turning into a fuddy-duddy, but it's interesting, the inflation over the years, and that I think when we started the budget for what the CCG was about 320 million, and now it's close to 400. It's, you know, it's interesting to see over time how it's expanded. It's just an observation. Yeah, I know COVID has accelerated that too.
Yes, I think it's even more. I think when we just before we started, when we were getting ready, I think it was about 290. So it's even more than that. Right. No more? Okay, thank you very much. In which case, I thank everybody again, and we'll move on to the main business of the board meeting. I presume apologies are as already recorded, Jo?
Yes.
Thank you. Any declarations of interest? Anybody got anything to confess? Okay, thank you. The minutes of the last meeting, which I'm sure you have all diligently read. Everybody comfortable with them?
Yeah.
No correction, no suggestions for correction? Thank you very much. Any matters arising? Okay, thank you. Kate, the action log.
Thank you, Christopher. I think we're all missing Godfrey with the minutes.
Yes, yes.
The action log seems to be all of my actions, really, so it'd be nice to tidy some of these up. So 027, that was looking at the reporting back on the maturity matrix with our integrated neighbourhood teams, and it's detailed in my report that I'll present in a minute, but there's an enormous amount of work that has gone on there. And what I'd like to do, looking at the structure and looking at the outputs and their priorities, and also just supporting the team through returning some of their ways of working that were pre-pandemic as well. I'd like to take that one off, and we can have a more detailed conversation at exec if you're happy with that, Chair.
Thank you.
The 049 was a community engagement group action, which I think was instigated when Linda was still with us. Again, I don't think that necessarily needs to remain on, because the conversations with the West Suffolk College are progressing very well. Actually, we're doing a brilliant piece of work, which I'll update in more detail probably at the next board, looking at sustaining our future, working with some of the groups of children around there, just capturing what makes them happy, what motivates them, what they would like to see differently, and what their learnings have been, you know, personally over the last year. So there's a large event that we're planning to kind of showcase some of those. So it ties in nicely, and the college have been incredible in terms of supporting how we get their voices heard and fed into some of our alliance conversations. So again, I shall bring back a report on that. It probably will be end of this year, beginning of next year, but I don't think the action needs to stay on unless, I don't think David's on the call, unless anyone's got anything else that they would like to see from that action. I think that one can be closed.
Yeah, fine with that. Thank you.
Okay, Brill. And then the last one was around gosh, my mind's gone blank. Oh, this was around sustainability, and we've got that on the forward planner with brilliant Andrea Urquhart, and Amanda's been working with him on that. So 071, Paul, do you have it? That's complete. There's nothing else to add, I don't think, unless you've got anything you'd like to chip in with.
No, sorry, Kate. No, I circulated that of the action.
Yeah, brilliant. And then we've got a deep dive into prescribing, which is, I think, on the forward planner for the end of the month for exec. And we've had one of the meds management team who went away on secondment quite abruptly. Brilliant development opportunity for them, but it kind of pushed the timings for that back slightly. And then the last one was yours, Lisa, on 072, looking at risk appetite.
Yeah, that's been updated to treat. Thank you.
Okay, so I think that can probably come off then as well.
Yeah.
Okay, so we're all clear, aren't we?
Yes, we are.
Have a clear action log. Thank you very much. So anything on the action log next time will only have been put on this time. Thank you. Ed, general update? Anything left to say after your previous speech?
Thank you, Christopher. So just a couple of things. So firstly, we're sending out a letter to all primary care teams in our ICS today, just to offer some support and solidarity, because all over the health and care system, teams are working incredibly hard under unprecedented demands, but certainly the primary care teams are doing that too. But there's been a lot of negative press nationally and commentary nationally, and unfortunately that's led to some unacceptable abuse and a perception that the GPs haven't returned to work, which really isn't true. If we look at the largest partnership in Suffolk Primary Care, their data shows that in the last week they had contact with 23% of their patient list, which is double what you'd normally expect. So people are getting through huge amounts of work, and we wanted to sort of set the record straight locally. Secondly, just to recognise that there's a change of leadership at West Suffolk Foundation Trust. So Stephen Dunn has stepped down from the trust and has taken up a role with the Nuffield, where he's a senior fellow working in an academic sense now. And then Craig Black, who was Steve's deputy, has stepped up as the acting chief executive and is doing an excellent job. Has brought a lot of stability and continued with the strategic work that the Foundation Trust has been pursuing. The final thing I wanted to say was around vaccination. So we've moved into another new phase with this. In terms of our 16 to 17-year-olds, over 70% have had their vaccine. They're only going to have one jab, which is very, very strong performance, and we're working closely with sixth form colleges and higher education on that. NHS England have commissioned a school-age immunisation service to vaccinate 12 to 15-year-olds in schools, and that programme is underway with an aim to complete by half term. 12 to 15-year-olds at risk or living with people at risk are being vaccinated in the coming week. We're expediting that work. And then thirdly, we've got a major national booster programme has been launched to give a third jab to people in cohorts 1 to 9. This is for people aged over 50, living in a residential care home for older adults, frontline health and social care workers, people with underlying health conditions, and people living in a household with immunosuppressed individuals. The booster is available 6 months after the second jab, and in most cases people will be given Pfizer, and the national booking system will be in touch with people when their time is ready for that booster jab. So the key message is to wait for that invitation rather than to chase your local GP. So there we are, a huge amount of work on vaccination. And just finally, the flu programme is up and going, and it's possible, technically possible, to receive a booster and a flu vaccine at the same clinic. Thank you, Christopher.
Thank you very much. Any questions for Ed? Oh, many thanks, Ed.
Oh.
Yeah, we have Lisa.
Sorry, not a question, but I just wanted to mention that West Suffolk Hospital won an award at the National Patient Experience awards ceremony. So they set up a helpline during COVID to support relatives to get information about patients, and they've had something like over 40,000 calls through this helpline, and over 70 members of staff were working on it. So I just wanted to give a shout out to West Suffolk for an amazing achievement.
Thank you very much. Right, moving on then. Strategy and service development, starting with the West Suffolk Alliance update. Kate.
Thank you, Christopher. And I just want to underscore what Lisa just said there. The case studies attached to that line are incredibly powerful, especially for all the end-of-life patients who were facilitated to speak to their families during the peaks of the pandemic. It might be something that we circulate the kind of report. I think it was a significant achievement. It impacted hugely on people's lives. So the integration report is, as always, large. So I'm just going to pick out the kind of the headlines, and I think starting from a place of just acknowledging, as Ed has just done as well, that there is a significant amount of pressure on every bit of the system at the moment. And I think we have to acknowledge that this has been in place, or has been the case over the majority of the summer as well, which is normally the time of year where people are regrouping, or we have time to catch up on some of our other set piece areas of demand. And as in 2.2, you can see we've just got a picture now where we have a rising walk-in demand into our emergency department. We've got delays around discharge because we've got significant risk and fragility around our dom care market, and also from a community perspective, dealing with lots of complexity in care is compounded the kind of overall picture. So I think more than ever, we can really feel the benefit of tackling some of these pressures as a system. And over the last month, we've been meeting daily with primary care, community care, the hospital, on occasion our voluntary sector colleagues as well coming in, and mental health, to talk about actually how we are managing risk and providing the services. And some of the schemes that we've put in place and some of the areas that we've been exploring are part of the work plan, which is detailed in 2.5, which I won't necessarily go into the detail. I suppose the point to note as a board is lots of these conversations and lots of the things that we are able to put in place were not something that we would have been able to do historically. And I think from the work that we did during the pandemic together, we've been able to look at a lot of the initiatives that were stood up during that time, and been able to think actually how do we introduce them more into our business as usual in this particular time of crisis. So we've looked at numbers of beds needed, we've looked at different ways of supporting people during their discharge, and looked at more holistically about how we kind of recruit as a system, because it's everybody's challenge, and as always, each bit of it is connected. So if somebody is unable to be discharged out of the hospital, that has a knock-on effect to the front door as well. So I'm not going to go through those in detail, but the detail of them is there, and I think hopefully they represent, and I'd just like to acknowledge the enormous amount of work that is underway at the moment from our frontline staff, but also those who are trying to work out what can be done to improve the offer at the moment. Number 3, we're talking about, which is a fantastic bit of development, personalised care. We've got a bit of funding that's coming to the system. We've been able to recruit a dedicated manager, and this is part of the broader integrated care system piece of work, but really working with partners on how we support people to make individualised choices on how they want to manage their own care. And this is multifaceted, and I think that it's something that has been in place in pockets with business as usual and the way teams work. But it's putting a little bit more structure around them and making sure that people have got the right skills. Health coaching is listed as one of the approaches. We've rolled out we've rolled over the funding for that as a programme of work, and that supports training across so many disciplines of so many different organisations on how basically to have conversations differently with the person in front of you and create a person-centered approach with more of an emphasis on prevention and empowerment and self-management, which I think sometimes people feel they don't have time for necessarily to support, but the impact of being able to empower somebody to have more control and more direction of how they are managing their own care there's a huge evidence base on the impact that has on outcomes as well. In section 4, we talk about the realising ambitions, which is a fund we have brought to board before, that we worked with Community Foundation to implement, and we're coming to the point now, which is always the best bit really, where we look back at what has been achieved. And in 4.3, we're talking about, in total, we were able to allocate 458,459 really, if you're rounding up. But that also they were able to match that, which is one of the unique selling points that the foundation brings to these kind of projects, to increase the amount of funding available, and as a consequence, increase the amount of people that benefited from that funding. I think it's very impressive how they can demonstrate impact really, and I think the numbers they're given, over 8,662 people benefited from the funding, and 529 people volunteered to support. And I think that last number is really material, because all of those individuals also got an associated benefit out of the work that was done, and there's some fantastic case studies attached to that. We've put in there some of the quotes back from the Greenlight Trust, which is an incredible organisation. Having met with Tom, their chief exec, recently, just listening to the evidence base, the impact of that kind of support in a consistent way has on the people that they work with is phenomenal. And there's a fantastic video that supports that there that I would recommend to you, and we can send round the full report if anybody is interested. The early supported discharge for stroke has been in place for a long period of time. It was established in 2014, but I think the material change and a lot of work went into making this happen. The contract was transferred to the Suffolk Alliance in 2021 and April 2021, so just earlier this year, and already they've taken it and they've grabbed it and ran with it. And I think the point of difference is it's across the voluntary sector, it's across the county council, it's across the hospital team, and they're already working with Home First and understanding actually what do those individuals need to maximise their rehabilitation as early as possible within their home environment. There are some very moving a very moving case study later on as part of the appendix, which I think is worth having a read through. There's an update on our primary care mental health support that's going into our PCNs, our primary care networks and practices, and what's been brilliant to see is how it is being supported by general practice, and a very incredibly busy time figuring out how someone who fits into your team and works with you on a day-to-day basis is tricky. And I think I'm really proud and impressed by how our practices have taken the individuals that are coming and are in post and have been attracted to the role as well on board. And I think we're going to have some fantastic results. I can see Faraz on my screen, and he's already been trailblazing for this model for quite a long period of time. So we've built on the learning from Haverhill as part of rolling out the model. And the other couple of little bits to mention is Woolpit, who have ran our drive-through vaccination program. Was part of the vaccination program, ran our drive-through in Woolpit, and did quite a lot of work to get that over the line. Have put themselves forward for a HSJ award, and we've been shortlisted. So that process will play through. It's a long shortlist, but it is just a fantastic recognition of the work that went into it, and the team in terms of, again, it being not just about the practice, it being about the local volunteers, it being about the different organisations that sent people in the snow to support. So that's a fantastic example there. And then I suppose lastly, there's a bit more detail on the work that's being done with the integrated neighbourhood teams and communities. I always feel that's just an incredibly quick canter through, but they are the headlines, and there's more work under each of them. And we've chucked, although it seems to be given a haircut, we chucked the presentation around the early supported discharge into the appendices. Again, very colourful and worth a read. Happy to take any questions, Christopher.
Thank you very much. An awful lot of work going on there. Any questions for Kate? No? Thank you very much. It's all very impressive. In which case we should move on to the procurement update, a summary of the activity. Paul.
Yeah, thanks, Christopher. I'll be pretty quick. It's a fairly straightforward paper, as you say, which sets out the current procurement activity, but I'll pull out 2 or 3 things, if I may. Just to point out, obviously, that we decided to award the contract for vasectomy and surgery. 10-day standstill went uneventfully, so we are in mobilization phase. So again, that will go swimmingly well, I'm sure, and we'll monitor the contract as we go forward. Pathology, since we last discussed it at the last board, service specification has been agreed. We have drafted a paper that will make its way through our various committees to describe the process we'd like to follow in terms of our procurement process. Really important contract, and we need to get it right. So again, we'll refine that through the committee structure and bring to the board as appropriate. Not wanting to steal Richard's thunder later, just a bit of an update on sort of mental health procurement. And as you remember, which is very well trialed, we took a 2-pronged approach to procurement of mental health services. One was an assurance framework around the core service that had been provided by trusts like NSFT, which we are now doing and progressing through the workbook that has been provided. And the second half being those services we might wish to procure. We had an engagement event on the 24th, which was attended by over 100 delegates, which was quite successful. We're now finding our way through that and developing the framework, and we will bring that back in due course in terms of the services we may wish to procure out of that particular exercise. So I'll stop there, Christopher, and happy to answer any questions.
Gosh, thank you. Questions? Oh. Okay. Right. In that case, we go on to finance, performance and scrutiny. Financial planning and the extension of the temporary financial arrangements first, please, Jane.
Yeah, thank you, Chair. So I've probably given away my stolen my own thunder by explaining that we, in the paper, I was hoping that I was going to be able to update you on the allocations and the plans for the second half of the year. Unfortunately, we still haven't received the planning guidance or the allocations for the second half of the year. So there are a number of things that the paper is asking the governing body to do, which we formally need to do to make sure that we're in a position to approve our budgets and put us in a safe financial place for the rest of the year. So, but to just give you the kind of context on this, just as a reminder, as I said in the AGM, we are working under emergency financial arrangements. We've been given our allocation as a CCG for the first half of the year, albeit that's not as we would normally receive it, because the majority of the expenditure that we need to make flows through ourselves as a pass-through to our providers. So that's calculations that have been made for effectively block contracts for West Suffolk Foundation Trust, NSFT, other Adam Brooks, we will have a contribution towards that, and they are their normal payments plus amounts that have been allocated to the system for COVID and small amounts of growth. So we were expecting, there's a bit of a standing joke about when will this actually come out. We always say that next year's planning guidance always comes out on Christmas Eve. It feels as though H2 planning guidance is going to come out on Christmas Eve, which will be slightly late, but we were expecting it in early September, and then we were also expecting it yesterday, but hopefully it will be not delayed too much further. But we do know quite a lot about what it is likely to contain, and that's set out in 2.2 in the paper. So we are expecting it to be pretty much a continuation, a roll forward of the funding that we received as a CCG in the first half of the year, and we're expecting those block contract arrangements for providers to continue. We are expecting there to be an extension of the Elective Recovery Fund. You'll remember that that we are an accelerator site within Suffolk and North East Essex, and what that does, as well as the rest of the country, it enables us to take actions to be able to accelerate our work on elective recovery. And as part of that, over and above those block contracts that we pay to providers, if we exceed activity levels based on 1920, we are able to draw down additional funding as part of the Elective Recovery Fund. This is basically an incentive funding, but it also pays for the costs of that additional elective activity. And Paul, I'm sure, will talk more about that within the IPR, but we are expecting it to continue into the second half of the year. We're also expecting the hospital discharge programme, so this is additional funding that's being provided to CCGs to work closely with social care around admission avoidance and prompt discharge. We are expecting that to continue. In the paper I said partial continuation. We now believe it is going to continue for the remainder of the financial year, but it will close and finish before we start the new financial year on the 1st of April. What we also are expecting in our second half of the year is an increased requirement on efficiency savings. So in the first half of the year, there was a very small efficiency requirement for the NHS. We are expecting that to ramp up, not hugely in the second half of the year, but to be moving back to more normal levels. We're expecting as part of that some reductions in the funding that we've been provided previously to support COVID. But as I say, until we see the detail of those, it's difficult to put a figure on that. But it is going to be an increased feature for the second half of the year. And as an integrated care system, we are running an event on restarting and our efficiency programme on the 7th of October, should anyone be interested in attending part of that. Really just a stock take on activities that we've already got underway and how we can work together to make best use of resources for the remainder of the year, and particularly as we go into 22-23. So in terms of, so unfortunately I'm not able to give you any details, and in the paper I was anticipating that this would be the case. So obviously we've got our governing body today and then not again for another 2 months. So what I'm asking the governing body to do is to delegate responsibility for taking those allocations once we've received them, working those through into a financial plan and budget. I'm asking if we can delegate that to the Financial Performance Committee, obviously with details of that coming back to the governing body in September. So that's the first ask of the paper. The second ask is around extending the temporary financial arrangements that we've had in place for the last 18 months. There are two main things as set out in the paper. One of them is around continuing the COVID Resource Allocation Committee, which is a committee that's worked across the 3 CCGs, enabling us to keep track of those specific COVID resources that we've been given and to make speedy decisions where we've needed to around deployment of resources. So I'm asking the governing body if you're happy to roll that forward till the end of the year. In reality, we have massively reduced the amount of times that committee has needed to meet, but it has still provided a really effective way of monitoring items such as the vaccination programme. So I would encourage the governing body to support that recommendation. And finally, we made some changes to the delegated authorisation levels when COVID started. Given that we've only got 6 months left of the CCG, I'm suggesting that we leave those in place in anticipation of all of this being reworked for the new integrated care body that takes place on the 1st of April. In reality, as I've said in the paper, we've only used the increased levels on a very limited number of occasions, but I think as we go into winter, it's wise to just leave those in place in case they are needed. So a number of recommendations there in the paper, Chair, if you don't mind taking us through those for the minutes, that'd be appreciated.
Thank you very much. So the two principal ones, as I understand it, are to delegate to the Finance Committee the reception of the allocation and the formation of a budget for presentation at the next governing body. Yeah, we all happy with that? And the second one has just slipped my memory. Going to have that again, please, Jane.
Yeah, so the second one is to approve the emergency financial measures, which are basically the
COVID committee. Yeah.
The COVID committee and the delegated limits.
Delegated limits, yeah. We're all happy with that? I don't see why you shouldn't be. It's worked very well. There are no issues in that. Okay, thank you very much. Right, let us move on to the Integrated Performance Report. Okay. The Director of Performance Improvement.
Oh, okay, Christopher, I'll kick us off, and I'm sure my colleagues will then step in and pick up anything that I miss or any of their particular areas of interest. If I may, I'll just pull out a few things out of the report. I think just to focus slightly on community services at West Suffolk around Pediatrics, Just to update that we've now done a piece of work to understand the issues around 18 weeks, and in particularly around autistic spectrum disorder. We've put together a proposal that looks to deal with any historical issues around that particular service, any impact of that COVID has had in terms of waiting list, and any remedial action that are required to improve performance. That paper will now find its way through our committees for review, approval, and decision. So again, watch that space, but we have done a fair amount of work with our providers to understand what the issues were and what needed to be done to address that particular element of performance. Just moving slightly on to into the elective activity, because clearly that's been clearly an important issue for us as a system, as a CCG. And I'd like to just to start opening by saying that when you start looking back in terms of what the expectation was in H1, we have consistently achieved the threshold that has been required of us. If you remember, there was a 70% graduated to 85% in terms of achievement. The only slide as a system, the only slight differential being that obviously West Suffolk have had particular challenges around their elective activity because of loss of 50% of theatre activity. But despite that, have really punched above their weight in terms of productivity and the work that they've been able to support the system with. Of course, you'll remember that as a system, we signed up to an accelerated program. And that we undertook as a system to achieve 100% by the end of July, with the view that when our remedial actions around West Suffolk buildings were sorted, we would move towards 120%. Early indications are that we did achieve, or we think we were likely to achieve, the 100% end of July. We won't know that for the 4 to 5 weeks because the way SUS is reported, that is a technical term for the financial reporting. But again, really good news story in the sense that actually we think we've near or thereabout achieved what we think we would want to achieve. 120% being a far greater challenge, of course, as we move forward. The consequence of some of the things that we've actually done are quite significant, really. We've really dropped from 92 percentile over 52 weeks, from 57 weeks down to about 43 weeks, which is quite significant. There is a differential between SNF and West Suffolk when you break it down, which is a concern. But as a system, we've done really well, which equates roughly from having something like 7,000 plus patients on the waiting list down to about 4,000 in quite a short period of time. So again, good news story on that. The fly in the ointment, though, is that our waiting list is still carrying on to grow, albeit slower than it would have been if we hadn't sort of pushed the activity going forward. And one of the key issues which we are being closely monitored and requested to address is what we call our long waiters, i.e. for the time being, those patients waiting 104 week plus. And at the moment, when you look at West Suffolk, we currently have 89 patients that are mostly orthopedics, to be fair, that are waiting over 104 weeks. If you project that forward, and if we were not to do anything, that number would rapidly go up to about 400 patients. So again, we are working through plans at the moment with mutual aid, with SNF and other providers, mainly private providers, to try and address that issue by the end of March, which has been the expectation of the national teams in terms of addressing those patients. So our main areas of biggest concern are essentially TNO, ophthalmology, and gynecology are the key areas that we'll be focusing on to the end of the year. I think quite fundamental, and I think is worth sort of highlighting at board, really, is that there has been a tremendous amount of work done around mutual aid across the system, and I'd just like to highlight some of those developments briefly because I think they are really quite important and a way of the future in many ways. So we worked really hard to develop standard operational practices. In other words, patients can be operated equally both at West Suffolk and SNF if required in terms of aligning the various clinical processes and everything else. So again, a lot of joint up working at the operational level has happened. We've seen a lot of mutual aid around ophthalmology, which has resulted from dropping from an 83-week wait to 61-week wait, which again is quite significant. Of course, we've used private sector and of course we've used other means, but actually the mutual aid has been working really well. Some of our ENT patients have been treated from West Suffolk at SNF, again, sort of example of mutual aid. Same for general surgery. And we are obviously making full use of vanguard theatres and sort of the private sector to try and achieve some of those reduction moving forward. Just to layer that on top of that, there's been a request for a short-term capital investment to try and address the long waiter issues. Those capital proposals have gone in to region. They're due to go up to national, I think, around the 7th of October time. But of course, that doesn't take us into the longer term planning, which is what do we need to do to achieve some capacity gap moving forward into the future. And we're certainly waiting on various advice on that nationally. As Jane has said, we are still awaiting for the planning guidance, which makes it very difficult to plan for H2. What we do know, however, is that the rules are likely to change in terms of, if you remember, I mentioned gateways previously. So in other words, there will be an ERF, so the additional payments that will depend on us achieving some gateway outcomes. Those are likely to be things like your 104-week wait, for example, and a number of other things. So essentially achieving above a certain threshold, i.e. probably 95% above threshold, plus achieving the gateway link, it will equal to investment into the system in terms of funding additional activity, and we're still awaiting that guidance to be able to understand some of those elements. So just to wrap up the elective, I think that it's a really good news story, but we need to do a lot more because we've got a lot more work. We've got a 2-3-year program, I think, to try and recover from our elective activity as we move forward. I'd quickly like to move on very quickly to emergency care, and I'd like to build on the point that Kate made earlier on around alliance working. The system will report, I think, that winter is already here, and we're just waiting for January to start hitting, if that makes sense. So actually, the fact that West Suffolk have managed on 2-3 less wards for quite some time, reduced capacity, and has managed to maintain flow is not only a testament to what the hard work that West Suffolk have done, but also the testament to hard work that actually the partners have undertaken to look at pathways, ensure timely discharges, make sure the appropriate discharge destination are for the patients, and the joined up working between all the partners around the alliance. So again, Kate has made some highlights of that. But of course, we are likely to hit quite a difficult winter, so we are currently planning for the winter because we will have a number of potential scenarios. COVID being an unknown, certainly a rise in activity. We will still be in the midst of some remedial work for West Suffolk, and we will still be discussing the mutual aid across the system. It's fair to say that the ambulance service, which is part of the IPR, has been under tremendous amount of pressure. They've been reporting what they call RIP4, which is the highest level of escalation. And if you look at the regionally, there has been significant delays in terms of patient, and I'm sure Lisa later on will pick up some of the consequences of some of those delays from a patient care and quality point of view. It's fair to say that we are less impacted because of the hard work that we've undertaken as a system, and whilst other systems are actively cohorting patients, at the front, we've not yet got to that point. But we are experiencing some ambulance delays, and we are trying to address those by working with the ambulance service. So I sort of stop there, Christopher, and happy to answer any question. I'm sure some of my colleagues will want to jump in on some of those issues and probably contribute to more detail.
Okay, any questions for Paul's section? Ed.
Thank you, Paul, and thanks for all that you're doing. I don't think we talk enough about community services, and looking at the data, the adult services are performing pretty well actually overall, which is fantastic given the operational pressures, but the children's not so good on the face of the dashboard, and particularly children in care not performing well at all. So I don't know whether you or Lisa could give a perspective on the kind of the children's community services.
I think at this stage, Ed, other than the stuff I've been involved around the ASD, probably Lisa, would you be able to come in?
Sure. I think children's services, community services in particular, are an area that we have been looking at over the last year, and Richard might want to comment. He's been one of the sponsors for the piece of work that we've done to review the community paediatric services. I think there is a real need to relook at the way that the community paediatric services are provided, and I think that would then make a positive impact on the KPIs. The children in care access into initial health assessments, again, that's a piece of work that we are working on with our county council colleagues, because a more integrated approach to that process. We know that the county council has the health assessment review team, and actually they do incredibly well, but our metrics around the initial health assessments, we haven't really managed to improve where we would want them to. So I think we are aware that there are some issues that we need to address, and through the review process and the new CYP strategy process, that will be picking that up.
Thank you. Richard?
Just to add to what my colleagues have said, so we've had an organisation called Rethink come in to look and review the Children's Community Paediatric Service hosted by West Suffolk FT. There's a whole series of recommendations that we've agreed in principle, and we're currently working through an action plan which the Suffolk Children's Board is owning under Alan's chair. That report with some of the detail is going to be going to the West Suffolk, I forget the name, the Health and Care Integrated Board meeting next month. So we're having a deep dive on children's. So that's where we'll go into a bit more detail. On the specific performance challenges, I'm not close to the Connect one, as Lisa said, but in terms of some of the other areas, particularly around under 11s autism, we have got a recovery plan that's due to come to the executive, I think, next month. So there are specific work that's happening in each of the areas of challenge, but ultimately I think it links back to the overall Rethink piece of work, which again will be working through at the Children's Board and next month in the West Integrated Health and Care Group.
Thank you very much. Firaz?
Thanks, Christopher. Thanks, Board. Just for a clarification, when we look at the long waiting list for orthopedics and gynae, is it because of theatre issue or staffing, or is it both?
I think it's a number of things. I think you've had a reduction in capacity in the last several weeks in terms of the remedial work that's in other words, 50% reduction in capacity in theatre capacity has happened. Whilst we've been working with our private sector, that's not been enough. But at the same time, you had the issues around COVID, which built up a greater waiting list, and what you're now seeing is patients moving through into the waiting times. So the good news is when you look and start to profile what is going to happen in West Suffolk and the way the theatres are going to reopen to February, we will start to see an increase in theatre capacity, which will help. We will also start to see some additional capacity which they didn't have previously because of the transformational work they've done around day case surgery and that type of thing. But actually what it's going to mean is circa, and please don't quote me in the figures, but it looks like we may have about a 200% shortfall of patient where we need to have a mutual aid conversation across the system to try and address those particular long waits. So it's a combination of things.
Thank you.
Thank you. Any further questions? Okay, thank you very much. Thank you, Paul. We'll move on then to Lisa.
Thank you, Chair. So I'm just going to talk through a couple of programme updates before I go to providers, but just to give the board a flavour of patient experience and complaints and concerns that are coming through to the CCG and also escalated through Healthwatch and safeguarding. The biggest concern that's being raised from the public into our teams is around dentistry. I know that Dr. Hassan has been doing a lot of work and engagement with NHSEI specialist commissioning teams around dentistry, but I do think it's something that would be worth taking through our next clinical scrutiny meeting to have a really good review of that. Certainly our Suffolk County Council colleagues and safeguarding partners are raising concerns about access for children in care into dentistry and also emergency access. So that's a real big concern coming through from a number of areas. The other biggest feedback that we continue to get, although it has improved somewhat, and I'll come on to talk about ESEC later, is around patient transport services. So just to talk through a couple of the programmes that I lead on. So Transforming Care programme, we continue, as you know, we've always done incredibly well in Suffolk, and we continue to do well. We have across Suffolk at the moment 3 inpatients, 3 people with learning disabilities in inpatient facilities who are CCG commissioned, and they all have treatment plans and discharge dates, and the independent panel process for the CETRs, that's the care, education and treatment plans, are in place, and our host commissioner visiting arrangements are in place. As you know, we have a responsibility to visit any Suffolk patient that's an inpatient to ensure that we're happy with the treatment plan and to make sure that we're happy with the quality of care they're receiving, and we are up to date with that. The maternity programme, I just wanted to update the board around some great work that UK Babies has done for our Suffolk and North East Essex maternity programme. So when visiting and antenatal classes were reduced during the pandemic, UK Babies, we commissioned to do online antenatal programmes, and we received a report at the local maternity boards, the last meeting that we had, and the satisfaction rate amongst women and partners is at around 98% for the online antenatal education. It's been hugely accessed across Suffolk. Hundreds of people have accessed. They are in relatively small groups. They're still in small groups, and they have WhatsApp peer support mechanisms, and it's been incredibly powerful. The one piece of feedback that we're getting from the families is that they would like it to continue postnatally. So at the moment we've got a pilot for it running antenatally, but we would like to offer it postnatally. The current pilot ends in December, so we're just looking at how we can make sure that we can progress it for people that want to access online programs, because some people will want to go to face-to-face, but the webinars are available to download later, and the feedback has been that people are able to re-watch it. People are able to watch it with other members of their family, and it's been really extraordinary. So just a great example of how the voluntary sector has helped us during the pandemic, and how they offer incredible value for money, and innovative and creative ways of doing things. I don't know, Andrew, did you want to come in before I continue?
Well, I thought I might update the board about dentistry. I sort of feel slightly reluctant to do it. NHS England has started a procurement process to secure new providers of dental services, but unfortunately they've decided not to go through a procurement process for Bury St Edmunds, which for us in West Suffolk is very disappointing. They are going through a procurement process in Thetford, for example, and that's an area with very little provision of NHS dentistry, but so is Bury St Edmunds, but they've chosen not to provide a procurement process. And anyway, the procurement process they're going through won't actually offer any services until July 2022, and there is a problem now with access to NHS dentistry. So it is somewhat disappointing. I understand that the team has been thin on the ground because of COVID, but I do think it has been neglecting people who have ended up pulling their own teeth out. They have been so distressed by their symptoms. Thanks, folks.
Ed, do you want to comment?
Do we know why Bury wasn't chosen?
No. Couldn't get an answer to that. The contracting team who are doing the procurement were not available to us, and because the procurement is active, they couldn't answer the question.
Because I know they're procuring in a smaller town like Leiston.
Yeah.
You know, Bury is obviously a lot bigger, so it seems strange.
Well, Leiston lost both of its dental practices over a short space of time last year in the middle of the pandemic, and so Leiston has no provision of dentistry, whereas Bury has got one practice left.
Thank you, Andrew. And I think it would be good to bring all our elements of intelligence through into clinical scrutiny, because there's so many pockets of information in different areas, and certainly one of the areas that's being raised with me is around the inequalities piece. So people who are reliant on NHS dentistry are unable to access appointments, as well as people who have private dentists. So it's a massive, I think, health inequalities piece, but it would be good to look at the data, I think, around that.
There is one other aspect to it which I might just mention, and that is that there is no capital money being offered by NHS England to dental practices. If you're a dentist in Scotland, you are being provided with capital monies to buy electric handpieces as opposed to air-powered handpieces, which are safer from the point of view of aerosol generation. In Scotland, they've provided funding for the provision of air extraction from dental practices so that you get a faster turnaround after an aerosol generating procedure, and none of that is being offered by NHS England. There seems to be an inertia around dentistry, which is really engaging the dental community in a big way, but unfortunately it's negative.
Thank you. So moving on to providers, nothing hugely to escalate around West Suffolk Hospital. The infection prevention and control processes that the Director of Nursing has instituted are working really well. They have really robust oversight of both infection prevention and control, and they have a multidisciplinary panel that reviews staff returning to work following contact with COVID, which I think is serving them well. They've currently got 15 COVID patients in the hospital, and I think some of that is around the oversight that they have around infection prevention and control. Staffing continues to be a challenge, particularly, you know, the number of staff that are household contacts who are unable to return to work, and particularly their midwifery staffing at the moment, which is, as we know, a national issue, is causing them some challenge, but they are doing everything that they can to recruit and to look at different ways of managing their midwifery staffing. They, as I said, they won the award for their clinical helpline, and they were also runners-up for the staff engagement and improving staff experience category at the Penner Awards, which I think is amazing for the trust. MHRA, you will know previously there were concerns around the blood transfusion service, but the trust has recently been advised by the MHRA that they're no longer under surveillance, and they have reverted back to annual submissions and 3-yearly inspection regime. So that's good. I think probably if I just move on to E-East, as Paul said, that's probably my area of greatest concern around patient safety and quality, due to the significant demand that the organisation is facing and some of the delays that patients are experiencing in getting a paramedic crew to them. So we have seen an increase in serious incidents relating to delay. I'm also concerned, we had the regional E-East quality meeting yesterday and had a long discussion about some of the hidden harm that we might not see impacting on patients at that point, but could impact on patient outcomes further down their treatment plan. And I'm hoping to work with Dr. Molyneux at West Suffolk Hospital around how we can actually understand some of that impact when patients wait a number of hours to receive conveyance into hospital and then develop acute kidney injury or pressure ulcers, etc., and actually how we can understand some of the harm that can be caused from that delay in conveyancing a little further down the patient treatment plan. We are looking with the system at making sure that any delays in access into the ambulance service, if they have been if they are at time of system pressure, there is a system review of that, so that actually the system understands and learns from that. Sometimes some of these incidents are a little hidden from other partners within organisations, so we're pulling together a proforma, a process, so that to make sure for EEAST there is consistency across the 6 ICSs around that process. I think there's a huge amount of other pressure that's coming through EEAST as well. So, for example, coroner requests, as you know, the coroners have increased the number of inquests that they are doing since the pandemic. EEAST are receiving around 40 coroner requests a day. Usually they have around 10 requests a day for statements and attendance at coroner court, but at the moment they're receiving around 40 a day as the coroners catch up with inquests. So yes, a huge concern to everybody, I think, and really keen to support EEAST to make sure that patients are kept safe. The other organisation I'll just raise is ESEC. So as I said at the beginning, we continue to have patients contact us around concerns of transport delays and delays in collecting from hospitals, usually to return to care homes or to their own home. ESEC hosted a multi-stakeholder workshop a couple of weeks ago, which was very much a listening event for the directors of ESEC, to listen to the experiences from Healthwatch and from other partners. And it was a really powerful event, which ESEC have pulled together a multi-agency action plan around improving how they work with people, but most importantly, improving how they communicate to patients and the public around delays for outpatient treatment appointments and delays following discharge. So they are developing a public and patient engagement strategy, which will be co-produced with patients and Healthwatch, which will be a really helpful way to set their vision and to really think about actually some of the work that they can do to improve experience. But they were talking about some very practical steps around reverting back in all acute hospitals to the ambulance desk, but also having volunteers linked to that who were outreaching from the ambulance desk into outpatients, into the renal departments, to keep people updated about waits for transport back. So lots of great suggestions, and I know the directors are keen to do some quality visits to spend time with patients, experiencing their journey, and to spend some time in the acute trusts understanding the difficulties that delays in collecting patients from outpatient clinics or from wards following discharge, how that impacts on the acute trust. NSFT, it's great to see the emotional wellbeing hub improving. I think as an organisation, they are still under some significant pressures around demand and their workforce. They continue to have pressures around recruitment of workforce and sickness and people who are having to isolate as they are household contacts of COVID. But they have clear plans on how they are working through that. Thank you, Chair.
Thank you very much. Any questions beyond the discussions we had during the delivery of that? Yeah, Firaz.
It's not a question really, it's a comment about ESEC. I think we've been through it before with their not being able to cope with the demand. And I've heard from, a couple of staff who work for them really. I don't think the staff are happy, whether they don't feel they're supported and getting the appropriate training really.
No, and that was a big part of what we were talking about as well, around staff experience. What does it feel like to work for ESEC? West Suffolk Hospital have previously opened up their their training, to ESEC, and it's been turned down. But the directors are really clear that they want to improve the staff experience. They're very focused on their workforce because they know that to improve their workforce experience will improve patient experience. Actually, patients' experience of the workforce is good. It's similar to many of our providers, that actually the caring and the the actual workforce, when they come into contact with patients, is excellent. It's getting the access to services that continues to be a problem. But yes, staff satisfaction is a big priority for them.
Okay, thank you very much. Let's go on to strategy and transformation.
Thank you, Chair. So before diving into the slides, just some updates on other bits. So in terms of planning, we still haven't received the planning guidance for the second half of the financial year. I'm going to stop predicting the date because it always gets caught out. It was meant to be yesterday, so we're just trying to find out from NHS England at what point it will be coming through. As it stands, this is planning, just to be clear, for the second 6 months of the financial year that we're actually already in. It's not clear yet when the deadline will be coming. Well, the deadlines will be set for next year's planning. We usually get it on Christmas Eve as a Christmas present for us. So I'll update board members as and when we get news on both of those. In more good news, actually, on community diagnostic hubs. So you'll recall that this is a strategic development that NHS England have set following the Richards review into diagnostics across the country. There's an ambition to have in place across each ICS or integrated care system a number of community diagnostic hubs. We've put forward a proposal through to NHS England for the West to have that facility within the Newmarket Hospital. It is not definite. There is a lot more work that would need to be done, particularly as we don't yet know the financial envelope set nationally for this. But we have started to put a plan together with West Suffolk Foundation Trust and other partners in terms of what that could look like. Further guidance has come out from NHS England related to the ask that all acute hospitals form a part of a collaborative by the end of March next year. So what does that mean? In essence, that means that within an integrated care system like ours, the acute trust, so West Suffolk Foundation Trust and ESNEFT, would work together to collaborate effectively where it would make sense on particular areas of need. So within the context of our area, we're particularly looking at the opportunities for elective recovery and cancer and some future strategic work that we've got going on in terms of the new hospital build in the West. So we've got a number of meetings coming up with our two acutes to explore what that might look like to meet that deadline at the end of March next year. And then finally, direct commissioning. So there is a basket of services that NHS England currently commission directly, including dentistry that we talked about earlier in this agenda. There is also a plan from the National NHS England team to effectively delegate responsibility for those service lines into the new ICSs if the Health and Care Act is passed before the end of March. Effectively that from April 2022, primary care medical services completely come back. The majority is actually now with with us through Kate, but there are some residual bits that will be coming back more fully, so it's completely our responsibility. The other services, including pharmacy, optometry and dental, would actually come over from April 23. So effectively another 18 months or so until that came through. And there is a program board, apologies, and a whole ream of different work streams that are currently working through the mechanisms of exactly how that would work and what it would mean. Just turning to the integrated performance report. So Kate and Paul have already covered a bit of ground in terms of the Integrated Care Alliance programme and also the elective work, which is in slides 237, 238 onwards. Just to pull out a couple of bits from that. So I think, as Kate mentioned, quite a lot of the work of the team at the moment is actually being spent rightly on supporting some of the operational pressures that are being experienced. So that has obviously had a knock-on impact on some of the longer term work that we're working through, but it's the right decision, I think. But having said that, and again, as Kate said, the Aging Well programme, which is looking at both anticipatory care and responsive care, is making good progress. And there's some business cases that we've had in the last couple of weeks that have been worked through and looked at in terms of being able to be financially signed off, which will also help us with our winter pressures that Paul said we're already experiencing now. In terms of the elective programme, just to make a plug for the eye care work that's happening. So we've now got an eye care board and programme across the integrated care system, which is effectively made for the 3 place-based alliance plans, but also we've agreed a number of pan-ICS areas of work that make sense to do once. So that's particularly looking at longer term demand and capacity planning. So particularly looking at optometry workforce and our community providers to see what more might be possible in the long term, medium to long term, if we are going to get on top of the increased activity and waiting list that we're experiencing within eye care services across the ICS. We've also progressed, I think, now at pace around what's called high volume, low complexity pathways. So there's around 27 national pathways that have been set as actually where there's opportunities to improve efficiency within those. So West Suffolk are leading that with our support. They've mapped each of those 27 and have now set out where they think efficiencies and improvements can be made within each of those, which I think will help in terms of what Paul was talking about in terms of our elective recovery work. Good news on virtual consultations that West Suffolk FT is still over the 25% national target, which is great news in terms of the proportion of outpatients that are seen virtually. And also the trust is making good progress with patient initiated follow-up. So effectively, rather than bringing a patient in, they're able to come back if needed through different mechanisms and given different support. That means they don't necessarily need a face-to-face appointment. Just turning then to some of our ICS-wide strategic programs. In terms of neuro rehab, just to say good progress now really in moving to business as usual, as it's known, around our stroke early supported discharge service, which is a partnership between West Suffolk FT and ESNEF. So that's now starting to make some real progress. And we've also got next month, just to trail to the for the executive, an options paper coming around neuro rehabilitation, level 2B and 3B. Don't ask me too much about that yet, but there are various requirements that we have as a commissioning organisation in terms of that. So the team are bringing through some costed options. Don't worry, Jane, I've not seen it yet. So we'll engage and make sure that we've got finances views on those before they come through. On the cancer programme, we had the cancer board meeting earlier this week, and we had a particular focus on a number of areas, including our breast cancer performance, which remains a challenge across the integrated care system, albeit particularly more in the east of the county. We're going to be piloting a new community-based breast cancer clinic model, which is based on really good practice within the East Midlands. And I'm pleased that we've got Professor Robertson, who's led that, is actually supporting us locally now in terms of what that could look like and how it would work. And we've got sign up from our trust in terms of now starting to move that forward. And we also had a particular focus on personalised self-managed pathways. So effectively, that's the other end of the model. If someone has been diagnosed with cancer and may have had their surgery or their treatment, how we continue to follow them up and support them. And there's some really good plans being formed within both our acute trusts around that. Moving on briefly to children's programme, we touched on partly earlier with the question from Ed on children's community paediatrics. we have the Rethink report that we're now working through, which is an independent report into our paediatric services. And again, as I said earlier, we'll be looking at that through the Children's Board and through the West Suffolk Health and Care Board, I think, in a couple of weeks. One thing that has come out of that is that we feel across the Health and Care Partnership for Children's that we need to develop a new strategic framework that looks over the next 5 years as a set of organisations. What do we need to deliver to actually improve outcomes for children and young people across our partnership? So we've got a lot of transformation activity happening, but it's not really hooked into what are we actually trying to achieve. So there's an agreement from the County Council, our acute trusts and ourselves, hopefully, that we do that piece of work together, including Waveney. So it would be a county-wide piece of work that we would embark on in the new year. In terms of neurodevelopmental, really good progress here as well. So you recall that the governing body approved, alongside Ipswich and East, a £700,000 recurrent investment in effectively support to children, young people and their families around pre and post diagnostic support. If a child's been diagnosed with autistic deficit hyperactivity disorder, autism or behavioural challenges. I think Paul's updated the board previously that we've now awarded those contracts through to a range of different voluntary care and social enterprise organisations, and mobilisation has now started for those, which is great news for families across Suffolk. I'm also pleased to say that we'll be bringing a recommendation through to the executive next month around the coordination function. Again, I won't say yet because we've gone through a process, but effectively we are in the position to be recommending now to the exec an organisation that we're confident could provide that function. So effectively, all, as it says on the tin, that coordination function would work across the different partners and support children, young people and their families as they go through the diagnosis process, because it is a little bit fragmented, put it mildly, at the moment. And that's been the big opportunity, I think, through the work that we've got going. On the mental health service side for children's, again, we are really at a point now where I didn't think we'd be a year ago, where we've now got an agreed model of care, agreed set of clinical pathways, nearly at the point by Friday of agreeing the demand and capacity modelling in terms of actually what does this look like over the next 5 years, and then overlaying that with the finances to look at exactly what we would need to bring this about. That's great news because actually it puts us in a position to start really implementing that agreed model, and indeed some of that has already commenced. Again, we'll be bringing that through to the Health and Care Board as part of the deep dive on children's in November. And then just to finish then on the mental health work, full of good news, more good news. So we had an event, I think, as Paul alluded to earlier in the agenda, where we went out to a market engagement event. We had 100 individuals come to that from a range of different small, medium, large organisations, predominantly from the voluntary care and social enterprise sector, who are interested in effectively joining our existing alliance partnership on mental health to be direct providers or support within that model. And we'll be bringing a paper to the October exec, so a lot of papers coming through, apologies, which will be looking exactly which services we think actually we could then go out to procure as part of that framework. So we'll be able to give you a bit more detail on that when we come through next month. And the assurance process, as Paul said, is starting around our alliance partnership in terms of the core model that we've gone through a number of times at the board and at the executive. And primary care mental health practitioners. So that's a core part, as I think you all know, of the model. Really, really good news in the West. We're nearly at full recruitment, which is amazing. And a big thank you, I think, to NSFT, Mark Patterson and his team, and also Julie Smith and the GP Federation team in terms of the work that they've done on bringing this about. It's really good news. And that's a key plank, as you know, of actually setting up the primary care-based mental health model. Except there's a lot of challenges around it, but it's really good news that we've encouraged and we've enticed those individuals. Quite a few of them are actually out of county to come and work within the service. So that's just a bit of canter through some of the progress we've made over the last month or so in the transformation field. Thank you.
Thank you very much. Again, an awful lot going on. Ed.
Just on the good news, well, so much good news, but maybe some of the best news around the mental health workers in primary care. I was interested, I could see Faraz nodding. What will it mean for you, Faraz, to have that? support in Haverhill.
As you know, Ed, and everyone knows, I mean, we've been working on that model for probably last nearly 2 years now. And at the beginning, we struggled. We managed now probably in the last year or so to get the model going. The important things really is reduce our workload as a GP. So one, if the patient phone with any mental health issue, we just straight away we put them with the mental health team. And the other really important bit which we have noticed is the Mdt meeting, which we have on a monthly basis, where everybody sit in there. So we've got GP, we've got the team from mental health, and we've got the secondary care psychiatrist. We've got the social care, we've got the social prescribing team sitting on one and discussing the complexity of some patient. So it has made a huge difference. I mean, there are still some issues, but generally speaking, I think we can see some improvement. And we're hoping now with having more, a bigger team now, so they can see more and more patients. So hopefully, probably in the next, probably toward the end of October, I think we will see even much improvement. So thanks for everyone who works on that team, please.
Just to add to that as well, we're also exploring appointing a number of children, young people's mental health practitioners. So there won't be obviously as many as we've looked at for the adults, but that will also provide additional benefits. So there's conversation will be happening with the PCN clinical directors and NSFT around that, but we have supported that in terms of a need.
Thank you. All very good news. Right. Do you want a break? You want 10 minutes for coffee and exchange of that. Okay. Right. We'll reconvene then at 10:55. Please put cameras and microphones off in the interim. Right, it looks as if we've got enough back to move on, I think. Jane, your hand's up. Did you want to start?
Yes, I just wondered if it'd be okay to just cover the finance report that was in the integrated performance, just very briefly.
Before the integration. Okay. Yeah, okay. Right.
Yes.
Yeah, if you'd like to. Yes, yes.
Yeah, so thank you. Just very briefly, within the integrated performance report pack, you've got the financial summary up to the end of month 5. We're also reporting the up to the end of the period we do know our funding for, which is month 6. So you can see the forecast for that as well. Just to report that CCG is on track to break even both year to date and in that forecast position. Within that, we are experiencing a range of pressures, particularly on primary care and on our continuing healthcare services. The Financial Performance Committee had a deep dive on continuing healthcare costs and at its meeting a couple of weeks ago, and we're continuing with various actions around that. So that's all I wanted to say, Chair, just for the notes that to show that we've reported the financial position.
Thank you very much. Okay, let's go back to integration then. Kate.
I think it's with a particular focus on primary care for me, Christopher. So I think we trailed some of it already in part of the conversation in terms of the level of activity and stress that is currently in this part of our system, and just I suppose as part of that, the only part I think of that we haven't necessarily covered is I think there is a piece of work going on at the moment just so that we can get a little bit of a better picture using data around where we are experiencing pressures and the quantum of change and how that is impacting in each of our localities. I think that's something that we're historically very well versed in looking at some of our other providers through that kind of lens, and the vaccination programme has given us much more insight into our local populations and their demands, their needs, and some of the demands as well. Rises in demands. So we're kind of using some of that methodology there. So it'll be something that potentially we will bring back. So just probably a point of observation, and also as part of the escalation work and understanding what, if anything, we can do differently. We're also working with our colleagues in the LMC and more broadly on if there is any additional support that we can put into primary care and looking at some of the core tasks as they stand at the moment on the administration side, if we can do anything to alleviate any of the pressures there as well. So that 2 bits of work in progress, really, just to note. And the primary care side is just a breakdown of the kind of dashboard of the key metrics. And I think this stuff that we've talked about before. We've had a slight dip in dementia. We've got a fantastic piece of work that's kicking off with some of our providers, and I think there's a session arranged for the board as well, looking at the patient experience around dementia. And the dementia board at an ICS level, at Suffolk County level, is going from strength to strength, I think, looking kind of across all of the initiatives that we've got in place around supporting people with dementia and their families and the diagnosis process. And I think that is sharing the ownership of the this is an indicator a little bit more broadly and helping to skill up people's understanding, I think, of what is out there in terms of support. I think there's anything else particularly to mention. We've got a pretty static position. We had around our CQC ratings and our patient surveys, and I think Jane has already given a breakdown of the financial position as it relates to primary care. With prescribing, we've had a couple of changes in our medicine management team, but all very positive, and we have got significant pressure, which we're quite well versed in, and a suite of actions that have been shared across the ICS in terms of how we support prescribing and improve quality of prescribing across the patch as well. So I'm happy to take any questions if anybody has any.
Thank you. We just need to trail that dementia experience session a little bit harder because 2 points for board members to note if you haven't tumbled to it already. One is you need to register for it, The diary invitation that you've been sent is not, I mean, it contains the registration link, but you've got to do more than just accept it. You've actually got to follow the link to go onto the website and book yourself in. That's point number one. Point number two is it is actually a face-to-face session in West Suffolk House. So don't book it and then think that you'll be sitting at your desk 2 minutes before. You've actually got to get there.
And on that note, we'll keep that under review given the current situation around face-to-face with rising levels of potential COVID infections in our patch as well. So we'll keep it under a watching brief as well.
Okay, thank you. Any questions for Kate? Thank you. Any more on finance, Jane?
No, that's it. Thank you.
Okay, thank you. Right, in which case we'll move on to the governing body assurance framework. Amanda, thank you.
Thank you very much, Chair. So here we have our latest GBAB, duly updated to reflect September. I may invite Paul to give a few words by way of update on RAC in a moment, but a few other updates if I may. So in terms of the white paper, we continue to manage that risk, and as you will see from the last presentation, we have actually reduced the risk rating slightly down to a risk rating of 12. I think it's fair to say the CCG has got a good grip of managing what it needs to be doing in terms of closing down the CCG in preparedness for March 2022. And in terms of things that we've done recently, we know that we have now appointed a designate chair to our ICS. We have accountable officer recruitment underway, which is due to be in November, and we are due to start the non-executive director and executive director recruitment likely around October and November. We also have a staff briefing with our staff on Monday, and we're going to be updating on the work thus far, including an update on the HR framework and how it affects them as individuals as we move forward. And that session is going to be in partnership with our trade union colleagues. In addition to another risk, we have since added a new one called system resilience, and that's really to reflect the local pressures that we are experiencing around urgent and emergency care at the moment. And in terms of our directorate risk registers, all directors continue to update and refresh, just so that we are managing locally before they may or may not be escalated to the assurance framework. I will pause there, Chair, but I'm happy for any of my director colleagues to update on their respective risks. And indeed, Paul, you may want to add a few words on the RAC risk. Thank you.
Paul, do you want to go on the RAC?
Yeah, I'm happy to, Christopher. So just to be clear, RAC standing for Reinforced Autoclave Aerated Concrete. We're very good at acronyms, but essentially, this has been really well trailed sort of publicly in the press and in other communication. But essentially, West Suffolk Hospital, as we know, was built of RAC material back in the 1970s. There was clearly a standing committee on structural safety alert back in 2019, which essentially set out that there was a risk of shear failure of any buildings made of that particular material. But I think it's fair to say, and it needs to be pointed out, that the Trust had been working with this since 2010. So I've been really aware of this for quite some time and been working, to ensure absolute patient safety and staff safety moving forward. That is not to decry the fact of this cost loss is a very real risk. I think from a CCG point of view, it's probably worth just making absolutely clear that we're not here really to assess the risk per se. That is for the Trust to do so from a legal point of view. What we're here to do is to make sure that we actually commission safe services. And I think we've done that in 4 different ways. The first way is essentially to make absolutely sure that the Trust are doing everything that is practically possible to mitigate the risk. And that's been done through ongoing conversation and review of the processes with some external support from external surveyor advice. So we've made sure we've dotted the i's and crossed the t's from a commissioning point of view. The second element of that is to make sure there are the right governance structures in place within trust to make the right decisions moving forward. And that is part of an ongoing conversation. We attend their risk committee, for instance. We invite them to our own risk committees. We have ongoing reporting. We keep a very close watch and monitoring of all the development that's actually happening with regard to the RAC issue. The second bit really is for us to explore whether we've actually done everything we possibly can in terms of commission services in an alternative way. And some of you will remember we did what we called an attained piece of work, which was a review of all the services and how they could be reprovided differently. That essentially concluded that we couldn't, for at least a couple of years, from the key services. So whilst you could take some small services out, it would take a couple of years and some significant investment, and the trust is balanced, if you want, the outcome of that report versus the overall risk. The only thing I would say to that piece of work is that it's being picked up as an exemplar piece of work sort of regionally, and that has been looked to be replicated in other areas where there is a similar issue. So a great piece of work in that respect. The other elements we would look at the RAC issues from a patient care environment. So again, is what it looks like, whether the patient can receive the right care, what the environment looks like, and we've clearly looked at that. And finally, the last lens really is around in the event of an event, would we be ready to be able to respond as a system? And we've done a significant amount of work with that and developed a local framework on how we would respond. That was tested back on the 19th of August, which is really, really positive. We've engaged region in terms of the wider response. And again, we're having ongoing conversation. And again, that work has been picked up regionally as a good piece of work. And we are continually reviewing our business continuity plans moving forward. So I think just to summarize, ultimately the solution to this issue is essentially a new hospital, and we've already heard that we have got a system first conversation. We are looking to build a new hospital by 2030, but it's clear and important to understand the steps that are currently being taken at the moment by West Suffolk, which are ongoing vigilance or what is actually happening and immediate action of any issues that are picked up and detected. There is a clear program that is looking at basically fail-safe program, which is due to conclude in 2023, and there is also essentially a being extension program which is due to complete this year, and then finally, of course, a new hospital will totally mitigate the risks. So I think we are pretty assured that the trust is doing everything that it can, but notwithstanding that the RAC poses a real risk, and we are aware of that, and we are providing the trust as much support as we can moving forward. So I'll stop there and happy to answer any questions.
Thank you. Any questions? Okay, thank you very much. I think that's everything for GBAF. So we've now got the Finance Performance Committee annual report. Jane, do you feel you've covered most of that already, or do you want to present it as such?
I'll just give it a brief introduction, if that's okay, Chair, just to say that this is a report which has been pulled together to hopefully explain to the governing body what we've been doing within the Financial Performance Committee during the last year. We obviously have Steve, who's the chair. I believe he's on the call. He certainly was earlier. I don't know whether he wants to add anything more about how the committee's worked, but it's just really, happy to commend the report and happy to take any questions.
Yeah, I'd just like to add, Chair, if I may, that in a very unusual year in many ways, not just in terms of COVID, but in terms of how the funding's come through and also looking towards the future, it's been a very challenging year for the team. And I'd just like to formally sort of reflect that, our thanks as a board to the finance team for all the great work they've done this year.
Thank you. Okay. In which case we go on to the Audit Committee annual report. Now, Jeff's not here, but Amanda, I think you've been primed to stand in for Jeff for this and the minutes of the meetings. Is that right?
Indeed, it is, Chair. Very happy to introduce, but my colleagues such as Jane may want to come in as well, and the respective leads for the committee. So in terms of the first item, I think colleagues will have read the paper. And Jane, is there anything further that you wanted to add by way of intro?
No, just to say thanks to Joe who drafted the report. We've discussed it at the audit committee, as it says in the paper, so it has been signed off, and hopefully it gives you a good flavour of the work that's been done at that committee during the year.
Thank you.
Jane. Shall I carry on, Christopher?
Yeah, I think we carry on to minutes of the meetings now then, please. Thank you.
Yeah. Okay, thank you very much. So here we have the minutes of the respective meetings that have taken place since the last governing body. And I'm very happy for either the chairs of those respective committees to pick up any salient points, or indeed just happy to open it up to questions from the governing body. Thank you, Chair.
Anybody spotted any issues they'd like to raise, or are we happy to accept those as are? What a smoothly running organisation. Okay, thank you very much. The next governing body meeting, part one, is at 9:15 on the 24th of November. We do have some questions from the public. Well, one member of the public actually, and it is from Margaret Marks, who, as many of you know, was Mayor of St Aylesbury at one point, and lives in and works hard for Haverhill. And she is asking, with the West Suffolk CCG integrating with Ipswich and North East Essex, and North East Essex having greater health demands, how can we be reassured that the available budget for West Suffolk will not be adversely affected or reduced by the need to support North East Essex? In other words, how can we keep our own resources in our own corner in when we're working as part of a larger patch? Ed, do you jump for that one?
Yes, yeah. And Jane may want to come in, but that's a question I've heard many times before, so that's a good question to ask. But actually, per head of population, I think we consume more healthcare in West Suffolk than we do in North East Essex, and of the three areas, the money's always been tighter in West Suffolk compared to the other two. So actually, that question will be asked in North East Essex of West Suffolk as much as it will be of West Suffolk in North East Essex. So it's not as straightforward as it may appear.
Thank you very much. Okay. She then goes on to ask, the new ICS will be responsible for dentistry, which has major challenges of availability and funding, as we partly discussed this morning. How do you plan to address these issues, and will a larger budget accompany this service from NHS England? I think I can probably answer that one. Do you plan to reintroduce dentists into schools, as many children are not currently able to access a dentist?
So,
okay.
I mean, others may want to come in, but dentistry will be coming across to us by April 2023, I believe. So we've got a little bit of time, but our eyes are open to the challenges of dentistry. I think it's going to be one of the toughest commissioning responsibilities we're going to have. So very happy to work with you, Margaret, if you've got a particular interest in dentistry, about getting the service into a better shape. Andrew talked about the issue earlier, and is very well versed on the challenges and opportunities. Yes, we're in sympathy with your question, and no, I don't think there'll be lots of resources coming from NHS England.
Then there's a slightly more detailed one on dentistry. can we understand the way that the unit of dental activity works or is monitored by NHSE, and how many units of dental activity have been used in West Suffolk in the last year, please? I suspect that if anybody's got anything about that, it's Andrew. Andrew, are you still with us?
I am, yes. Yes, I am.
Is there any straightforward way of answering that question?
I can't answer the part of the question which was about the way in which any units of dental activity have been redistributed over the last few years. In terms of the range of value of each unit of dental activity, the range in the east of England is from about just under £20 per UDA up to 35 or even more pounds per UDA. So for the same bit of work, you might get something approaching double the funding in one practice compared to another. The other aspect is that the new tendering arrangements, which, as I mentioned, have not been offered in Bury St Edmunds, are offering £32 per UDA, whereas the average in West Suffolk is £24 per UDA. So if you decide to set up a practice in Thetford, you'll actually be potentially offered a very significant premium over the adjacent practices. So I'm sure that represents an addressing of inequality, but I rest my case. You're muted, Christopher.
Lisa, have you got a contribution on that one?
The only thing I was going to say, I think it's a great question, and this is part of the data that we need to. I'm going to have a bit of a trawl with Andrew and Greg from our contracts team, who is our guru of dentistry, contracting and everything. To what I'm really interested in is the unmet need, and I honestly don't know if we're going to be able to get that, but we need to get all our data that we've got, and that NHSEI and the dentistry services themselves can support us with. But that's a really good point. Thank you.
And finally, I would say that it's a really good point to put to NHS England directly from a representative of the public, such as Margaret. Thank you, Margaret.
Thank you. And finally, Margaret asks, I think this is probably for Paul or perhaps Richard, are we asking the Lakenheath USAFE to help with any of the delayed elective surgery? They have a fantastic facility, and it may also prove a learning resource for their staff, as they normally only deal with a younger cohort of patients.
I'll have a go at that one, Christopher. And if I miss something, please others step in. I'm assuming we're referring to the RAF facility. The simple answer is no, we haven't. I think it's a really good question. I, however, suspect that these things are very centralized, centrally controlled and managed. So what I will do as an action from this meeting is have the regional conversation to see whether or not there has been some sort of national regional conversation about using alternative facilities, and I'll explore it and come back to the board. But to date, no, I don't believe we've had the conversation is a simple answer.
Okay, thank you. So we'll have that on the action log, I think, for the next board meeting, probably. Please, thank you. I think that's the only action we've taken from this meeting. Thank you very much. The public board meeting is now at an end. Thank you all for your attention.